Our next presentation is on fine needle aspiration biopsy for orbital tumors by Dr. Eva Dafgard-Kopp.
Thank you very much for the kind invitation to talk about this fine needle aspiration in orbital tumors. I have no financial interest and relationship to disclosure. As a question, do you send patients or do you do fine needle aspiration for any orbital tumors? Yes or no? A quarter said yes and 77% no. Okay, fine. Thank you. So sometimes the orbital lesions are rare and can be a diagnostic challenge. Because of the complexity of the anatomy, there are rather many tissues in a small compartment, which means that it's also a wide range of possible lesions. And sometimes, especially in the posterior part of the orbit, it can be difficult to do the surgical procedures. Fine needle aspiration biopsies of FNABs has been used in the diagnostic of orbital masses since the 1970s in Sweden. It's a rapid and minimally invasive diagnostic technique. In adults, it's done in an outpatient procedure with no local anesthesia or sedative, which means a reduction of health care costs. And also, orbitotomies may be avoided in lesions which can be managed with medical therapies, and also minimal risk of tumor seeding. In our setting, we discontinue anticoagulant therapy before, and is usually done by an ophthalmologist or a cytopathologist. Non-palpable lesions are done under CT or ultrasound guidance. It's done with a negative pressure with a 27 or 25 gauge needle into the lesion, into different locations to and fro, and thereafter the cytologists are looking at the aspirate. They stain the aspirate, and if it is enough to make a diagnosis, that is done. But you can do another go also. Also, you can rinse it in a saline and do flow cytometry or immunocytology or also genetic techniques. If there is a lesion which we think is an inflammation or a lymphoma, which is easy to take a biopsy in when the patient is awake, then we go for an incisional biopsy. If it is a lesion which is radiographically is ambiguously best treated with a total excision, then we do an excisional biopsy direct, for example, cavernous hemangioma. But for other lesions, we often do fine needle aspirations. When Richard Allen was working with me in our department in St. Eric Eye Hospital a couple of years ago, he was surprised of all the fine needle aspirations we wanted to have in all the orbital patients, and suggested a study and to see the success rate of the cytological diagnosis, if it was dependent on the location or if there was palpable, non-palpable lesions, focal, diffuse, or the size. We also wanted to look at the correspondence between the cytological and the histopathological diagnosis, and also complications. It was a retrospective chart review. All patients who underwent fine needle aspirations in the orbit between 2005 and 2013 at the Division of Clinical Cytology at the Karolinska Hospital, Stockholm, Sweden. All patients were referred from our unit in the orbital unit in St. Eric Eye Hospital. There were 225 fine needle aspirations, 58% women. The mean age was 54 years, which is interesting to see that 56 of the patients were in productive years. Remember that it was an out clinic, and you don't have to do any, it was just for a couple of hours they had to be there. 84% of the patients, 84% of the aspirations resulted in a cytological diagnosis. The most common was, not surprising, tumors, and after that inflammation and benign cytology malformation or cysts. When the clinical and radiological findings didn't correlate with the cytology, then we do incisional biopsies. And for the lymphomas, 23% of all the lymphomas went on further with an incisional biopsy. 48% of the inflammation went on with an incisional biopsy, and for the inclusive cases, 62% with incisional biopsy. Where we looked at the location, most of the orbital cases were, of course, supratemporally, but looking at the different part of the quadrants, we couldn't see any different in the diagnostic aspirates. So that was independent where in the orbit. But the deeper parts there was a difference. We looked at the anterior, we divided the cases anterior and posterior, and the anterior was the anterior of the posterior part of the globe. And there we saw a statistically significant difference, that it was more successful in the anterior parts. We also looked at palpable lesions, and they showed a statistically significant difference in the percentage of successful fine needles, but neither size or imaging appearance affected the rate of success to receive a diagnostic aspirate. Altogether, there were 27 of the patients who underwent additional incision biopsy, and 20% of the patients went a resection of the lesion, meaning that more than half of the patients did not have an incisional biopsy. So the cytology, together with imaging and clinical appearance and clinical history, was sufficient for diagnosis, and they did not need an open surgery. And in 97 cases, we could look at correspond the histopathology with the cytology. And with those, we saw that in the benign cytology, see if I can hear here, the benign cytology was the largest group where it was not corresponding with the cytology with the histopathology. And that is not so surprising, because if there is a benign lesion, or if it's an inflammation, there can be fibrotic cells, and if not so many cells. And that is also important to see that we have, when it is a fibrotic lesion or with a poorly cellular indication, when it's negative, for example, when it's inclusive or benign cytology, it is recommended to do an incisional biopsy. We had 2 false negative cases. One was when we suspected a lymphoma, and the cytology just was blood, and then we did an incision biopsy, and it was a lymphoma. Another one showed inflammation with atypical cells, and we had to do 2 incisional biopsies and found it was breast cancer metastasis. There are other studies, not so large, but one from Italy and one from India, which also find that it is a good correspondence between the cytology and the histopathology with, for example, pleomorphic adenoma, benign cysts, and also tumors. But where it's not correlate, it's the inflammatory process, inflammations, and also some cavernous hemangiomas, and also some lymphomas. And another one from India shows the same. It's a good correspondence in the lymphoma, benign tumors, inflammation. But here was one where it's inconclusive fine needle, which was showed to be inflammation, and also one with lymphoma showed inflammation when it was histopathology. So when should we do this and not? Absolutely for lacrimal gland tumors. It is reported that a misdiagnosis may occur in 20% or more of presumed pleomorphic adenomas. Lymphomas, I would say yes. This is controversial, but with the cytomorphology, immunocytochemistry, flow cytometry, and sometimes also cytogenetic techniques for subtyping, this technique confirmed lymphomas in 35 or 37 cases reported by Tani 2006. In our material of the lymphomas, there was 77% of the lymphomas actually treated of the fine needle aspiration diagnosis. And also we've seen in later studies that 60% could be subclassified just with the fine needle aspiration biopsies. And the remaining 40% were low malignant B-cell lymphomas. So also I would suggest it in cyst dermoids, granuloma inflammations, for example, tuberculosis or sarcoidosis, and metastasis. The many metastases may present prior to identification to primary tumors in up to 60%. And for malignant tumors, it's been over 90% specificity to find a malignant tumor. For idiopathic orbital inflammation, about half of our fine needle aspirations had to do a biopsy, and we can't detect an IgG4 related disease because that has to be histology. And also it is maybe with the benign reactive lesions. We don't do fine needle aspirations in the apex, and for vascular malformations it's usually detectable with radiology, and if you do that you mostly just get blood and not for optical nerve tumors. In the study we also looked at complications, because older studies reported of hemorrhage, nerve damage and puncture of the globe, and actually even death also. But nowadays when we do a guidance by CT or ultrasound and we do a cessation of the anticoagulant and medications, it's pretty safe, and no reports recently have been of these difficult, severe complications. We had just 3% complication with small hematoma. Usually the patients stay 1 hour after to check up that there won't be any severe hemorrhage. So in summary, fine needle aspiration biopsy is a rapid, cost-effective and minimally invasive diagnostic technique in an outpatient setting. A rather high success rate, 84% in a cytological diagnosis. Anterior and palpable lesions had a higher success rate than posterior and non-palpable lesions, but neither quadrant location, size or type of lesion affected the success rate. Limitations is poorly cellular lesions. We had high correspondence between cytology and histopathology. And altogether, when clinical and radiological findings correspond with cytology, appropriate clinical management is possible in a majority of the cases. And in over half of our patients, cytology along with imaging and clinical presentation was sufficient for diagnosis avoiding orbitotomies. And there were no significant complications.